do that. Okay, so now I will hand it over to Shey to introduce himself and to start talking to us about National Gay Men's HIV/AIDS Awareness.
Awesome. Thank you so much, Christina. And thank you everybody for having me. As Christina mentioned, my name is Shey Thorn. My pronouns are he and they. I am the co-executive director at AIDS Alabama South. I'm also the director of prevention, education, and outreach, and the clinical director of our sexual health clinic. My daily work focuses on addressing the needs of those living with HIV and ensuring that our services match what they deserve in life. As well, I personally have been living with HIV for over 11 years now. So this comes from a very passionate part of my soul as to why I love this work and I'm currently doing this work. As Christina also mentioned, after the presentation, we'll leave room for question and answer. So if you have any questions, you can always put them in the chat box. I believe Christina said that she would be watching out for it and we can, address those later on and save that. So Christina, am I good to go?
Yes, absolutely. If you put a question in the chat, we'll flag that to be done at the end. So don't think we're ignoring you. We'll just leave time at the end for us to answer those. You're good to go.
Sounds great. I'm going to go and share my screen. All right. Can everybody see that?
Yeah, Shey, it's just showing up in like the presenter mode. So we see the one on the left and then we see the upcoming slide on the right. I don't know
Got it.
if there's a way for you to adjust that or not.
Yeah, I believe there is. Did that work?
Yep, perfect.
Awesome. All right. So as previously mentioned, let me see if I can change that on my side. Well, I'll just be looking to the side. All right. One second, I apologize.
While Shey's getting set up here, I do just want to say that we had originally thought that Tony Kristen Walker, which is our board chair, we thought that he would be presenting, but he had some family issues come up. And so Shey very graciously jumped in really at the last minute. I think he was told yesterday, or he was asked yesterday to do this presentation. So I just want to say a huge thank you, Shey, for jumping in and being so willing to talk about this.
Absolutely. It's an honor and a pleasure both. Tony, I will say a few things about Tony as well. Tony is my mentor. He's also my best friend. And we are absolutely thinking of him today as he attends a very, very close person in his circle's funeral because of COVID. But he wanted to be here so bad and do this. So he did, as you can see on this first screen, he created most of this PowerPoint. I kind of just jumped in last minute and expanded upon some of those things. And there's his information at the bottom. He is the Director of Prevention and Community Partnerships at AIDS Alabama in Birmingham. And I have all of his contact information. I'll be providing you all with my contact information at the end. So if you want to reach out to Tony as well, just shoot me a quick email or call me and I'll definitely reach out to him. So we're here to talk about National HIV Awareness Days, most specifically our Aging and National Gay Men's HIV and AIDS Awareness Days. So the first one coming up will be the National HIV AIDS and Aging Awareness Day, and that will happen on September 18th. So it's just a few days away. And then up next, behind that will be National Gay Men's HIV AIDS Awareness Day. So first, I'm going to focus more on aging, and then we'll jump forward to the National Gay Men's HIV AIDS Awareness Day. So we do have 40 years of progress now, and it's officially time to end the HIV epidemic. We have all of the tools at our fingertips, and we will definitely expand on what those look like throughout this presentation. So in a means to address ending the HIV epidemic, we have set 4 for 40, and those 4 are reflect, recommit, re-energize, and re-engage. And this June 5th, which already passed, the world marked 40 years since the first 5 cases of what later became known as AIDS, when that was officially reported. And the United States Center for Disease Control and Prevention, we know it as the CDC, Morbidity and Mortality Weekly Report described those 5 cases. And when we take a moment to look and see how the government and community observed that day, it's starkly different from the way we approach these situations now, as well as eerily similar, especially with what we're seeing now within COVID and the pandemic. So 4 for 40, reflect, recommit, re-energize, and re-engage. What does that mean and look like? So first, in reflecting, we need to reflect on those that we have lost to AIDS and also our shared progress towards ending the HIV epidemic. I will admit I am younger than most people think. I was born in 91, I'm 30. So I was right at the cusp after, those first 5 cases and really HIV/AIDS became so prevalent, which is almost ironic to where I am today and how life comes full circle. But reflecting back on what especially the gay and bisexual, more specifically the gay community faced and had to endure during that time as they watched their best friends, their family members contract this unknown disease that everyone was so absolutely afraid of, scared to death of, and not have anything, not be able to help them in any way. And I can't imagine being in those shoes. I can obviously put myself in the shoes of someone who's living with HIV and receiving that diagnosis, but that comes so many years, 30 years after those original 5 cases. So it does not align. And all we can do now is reflect back and try to understand and better remember the history of where HIV and AIDS first began so that we ensure that history does not repeat itself and that we can finally move forward. On June 5th, 1981, the Center for Disease Control and Prevention released the Morbidity and Mortality Weekly Report and listed 5 individuals who had pneumocystis pneumonia. And none of the men had any connections, and 2 of them died shortly thereafter. These would be considered the first cases in America. And I think that one sentence, that none of these men had any connections, is quite important. Because whenever we think about HIV and AIDS, especially when it comes to gay and bisexual men, in some of our minds, we think of clusters and we think of small groups of people, or the stigma prevails and we think of the ongoing stigma of gay and bisexual men are hypersexual and have sex with multiple partners or people throughout their life, and they have sex within their circles or their friendships. But these individuals have had no relation, no connection whatsoever to one another. So that also further indicates how much more widespread this was outside of just those individuals that we know that were diagnosed with at that time was AIDS. And in looking at Alabama's aging numbers from that time, luckily with the implementation of different viral antiretrovirals and what those have looked like over the years, AZT, ART, we have found something that works in medication. And so we do now have an aging population of individuals who are living with HIV, which is beautiful and it's needed, especially for those of us like myself living with HIV, because that allows us to have that voice and that remembrance of what was and where it was and how it happened. So that we can truly understand the meaning and the need to continue this fight to eventually and finally end the HIV epidemic. To the right of that screen, you will see that in 2020, 15.8% of new HIV infections were among people 50 years old and above, and 45% of people living with HIV older than 50. So that's almost half of individuals living with HIV are within that HIV and aging group. And I believe something while we're here, I think it's also important to note that within that 20 to 24 age range, we're also seeing smaller increases of HIV within those age ranges too. So in addressing HIV and ending the HIV epidemic, that needs to become a priority population as well. Alabama's sexual orientation numbers. In 2020, 21.3% of new HIV infections were among men who have sex with men. In our industry, we refer to them as MSM. And 45.7% of people living with HIV were MSM. And these numbers are probably much higher because 51.7% of new cases reported unknown risks. And 15.5% of those living with HIV also didn't report any known risk. And when we talk about known risk, we're looking at what their sexual history over the past year may have looked like. With men, did they have sex with women or both? A transgender individual, sex for drugs, food, money, or something that they may need. And for such a large amount, 51.7% of those newly diagnosed to not report any risk whatsoever, it does not add up. So we can assume that we can take that percentage and honestly divvy it up to where the rest of the percentages, to where it would equate to the rest of the percentages, and where we see that 21.3%, a very large number of newly diagnosed, were men who have sex with men. I think it's also important to note that in addressing this throughout the testing process, the diagnosis process, because of stigma and fear of retribution or retaliation, and we'll get to that later on as well, so many of those people who are gay and bisexual are still afraid to come out, and even within a confidential clinical setting, admit or say that this is the sexual encounter that I just had. I did have sex with a man, or I have sexual relationships with men, and so that filters through to the stigma that continues to persevere throughout HIV and AIDS as well. But it also lends towards that risk not reported part, where we have to assume, it's smarter to assume that because anal sex is at one of the highest risk of passing or contracting HIV, that risk must be in there somewhere. And for 2021 preliminary numbers on orientation, we can see that of those cases, 78 of the 171, just from this year alone, had no risk reported whatsoever. So that fear, that stigma, that discrimination, it's still alive. It's still happening, and it's still affecting our community members. But as we see, it's affecting our numbers, and we rely on these within the work that we do so that we can better address those communities who are most disproportionately affected. And so through these actionable items that we're going to get to throughout this presentation, I believe that we would see, that risk not reported or unknown number greatly reduce. And so we can better acclimate those numbers to the other adult and adolescent exposures above the age of 13 years, so that we better understand where HIV is truly impacting within our community. And honestly, we have a great idea, because of those cases in 2021, 65 have been men who have sex with men, and 26 have been heterosexual individuals. And typically that is heterosexual African-American women. That's our, one of our next higher proportion or higher disproportionately affected populations. And this is a beautiful quote by Audre Lorde that Tony had put in here. And Audre Lorde was a self-described Black lesbian mother, warrior, and poet. And she dedicated her life and her talents to addressing injustices of racism, sexism, classism, and homophobia. And she's known for saying that my silences had not protected me. Your silence will not protect you. But for every real word spoken, for every attempt I had ever made to speak those truths for which I am still seeking, I had made contact with other women while we examined the words to fit a world in which we all believed, bridging our differences. And I think that quote alone gives me chills thinking about the many layers that holds within it. Seeking wisdom, maintaining that silence, which leads to perpetuated fear, perpetuated mis or non-education, and all of that filtering through to what we know as stigma as a whole today, especially stigma surrounding homophobia and HIV, and that through making that contact with other women to examine those words that they were trying to understand and fight for, they were able to essentially have easy conversations to bridge those differences and to come to a conclusion. And that's really where we're at right now. And it's all honestly very empowering. So what does recommit mean and what does it look like? In 2019, the federal government introduced the Ending the HIV Epidemic in the United States, better known as EHE, which provides a targeted infusion of new resources and support to local communities in working together and with federal government to end HIV epidemic in America. To achieve maximum impact, the Ending the HIV Epidemic Initiative focuses its phase 1 efforts in 48 counties, Washington, D.C. and San Juan, Puerto Rico, where more than 50% of new HIV diagnosis occurred in 2016 and 2017, and an additional 7 states with a substantial number of HIV diagnosis in rural areas, bringing the total number of phase 1 jurisdictions to 57. In order to end this epidemic at the national level, we must start with ending it at a local level. And ironically, at a local level, both within Birmingham, Montgomery, Mobile, wherever you are throughout the state of Alabama, we all are within those 57 jurisdictions. Alabama is listed. Birmingham, number 1 at the top of our list for Alabama. Mobile falls between 2 and 3 very, very often. Montgomery right up there. We continue to see these new prevalence of HIV, these new diagnoses, this increased risks, increased clusters that pop up in HIV. And so recommitting to helping end the HIV epidemic everywhere was essentially a call to action and a cumulative support, everyone coming together to address and assess where we needed to create the most impact to address HIV and to ultimately reach our goal of ending the HIV epidemic. In that map at the top right, you can see where those 57 jurisdictions are dispersed through. And the color, the golden color, does designate, as well as the striped, the phase 1 action. Moving on to re-energize. Re-energize the HIV response by ensuring equitable access and reinvigorating our efforts. So HIV is no longer a death sentence. And if you have more questions about that, I would love to answer that towards the end of this, as I don't get too much into the HIV education part. But it hasn't been for a while. And for us to recognize that fact that for so long here in Alabama, we, in the South, in the Deep South in general, we've associated HIV with an end of life, even more so than a cancer diagnosis or something, more terminal or more detrimental. And it has not been that for such a long time. And there's so many factors that play into that, and so much amazing knowledge that needs to be taken from that and then dispersed and taken out into your communities. Unfortunately, HIV is still a huge problem in the southern parts of the United States and is disproportionately bad for Black men who have sex with men in the South. And Black women and the Latinx communities are not far behind. Their numbers are right behind that. We already know what we need to do. We have to make HIV a priority once again. And there are many people in the United States who believe that HIV is no longer a problem whatsoever. So it's that, honestly, a beautifully horrible dichotomy of you have this large group of individuals who believe that HIV is the absolute worst and terminal illness that you can receive, diagnosis you can receive. And then this other portion of the population who thinks that it's no longer a factor in our life and doesn't really affect anyone. And we have to do a better job of educating our youth and the general public about healthy, safer sex practices, prevention methods, what is accessible, what organizations are out there, what can you do to prevent yourself from contracting HIV, but also help your friends, peers, coworkers in educating them. And I think through re-energizing our efforts, through participating in webinars such as this, we can truly become a factor, a playing member in ending the HIV epidemic through taking that education that we learn back into the communities that we serve. Moving on to re-engage with our partners around the world to end the HIV epidemic. And we must work collectively to re-engage people with lived experiences as well as stakeholders. So that lived experience goes back to the HIV and aging world. We need to rely on those voices of individuals who have been living with HIV for 30 years now. We're seeing people living with HIV for 30, 35 years now. And we need to activate them within the work that we're doing, within conversations such as these, so that their voice, their experiences can be heard, and so that we understand where we come from, what we have accomplished, what have been our barriers, and so that we can better assess what we need to do to re-engage and move forward in addressing ending the HIV epidemic. And we must encourage re-engagement into HIV medical care and treatment. And that is a big factor. Obviously, those individuals who are living with HIV and are not in medical care treatment are exceptionally higher risk of passing the virus along. And that's because medicine works now. Medicine works so well that from one pill once a day, an individual can reduce their viral load, which is the amount of HIV in their system, so low that it cannot be detected by any known test, which also means that undetectable equals untransmittable. Therefore, those individuals cannot pass HIV along to any other person under any circumstance. And so through expanding, eliminating that stigma, talking freely and openly about this, educating ourselves, re-engaging those individuals aging with HIV, and then re-engaging them into care and assisting with that referral and that linkage and that support, we can ensure that those who are living with HIV continue to be undetectable, virally suppressed, and cannot pass that virus along. And that is one big factor in addressing ending the HIV epidemic, and it's re-engagement in care and medication adherence. And ultimately re-engage all sectors of society, every community and every person, regardless of their HIV status, so that they can work together to end the HIV. I mean that in a situation such as this, I may be the only person here living with HIV, and while I'm leading the conversation, just by participating and gaining this knowledge, we're re-engaging with you all so that you can take this back out and engage other individuals, and let them understand that your HIV status, although you should know it, and as per the CDC, everyone between the ages of 13 and 64 get tested at least once per year, that regardless of that status, whether you're positive or negative, it does not mean that you cannot play a part in working together with your community as a whole to end the HIV epidemic. So moving on to National Gay Men's HIV/AIDS Awareness Day, what is the need for it? Well, if you look at that picture on the right, that infographic, 69% of the 37,968 new HIV diagnoses in the United States and dependent areas in 2018, just a few years ago, 69% were among gay and bisexual men. And that alone, over half, that alone speaks to the need for this National HIV/AIDS Awareness Day. And gay and bisexual men are the population that is most disproportionately affected by HIV. Over half of people with HIV are gay and bisexual men, and most new HIV diagnoses occur among gay and bisexual men. Continuing that conversation, HIV continues to disproportionately affect gay and bisexual men who are younger, who are African American, and who are Latino. And nearly 330,000 gay and bisexual men with stage 3 HIV, also known as AIDS, have died since the 1980s. 330,000 died that didn't need to. And I think that's the easiest way to put that. And I'll touch on super quick, the 3 stages of HIV. You do have acute infection, which is where it's newly interacting with your system, right? And then you have clinical latency, where your body has not acclimated, but is in a latent stage of acclimating to the HIV within its system. And then if no treatment is applied within those first 2 stages, individuals typically do progress to an AIDS diagnosis, acquired immunodeficiency syndrome. because the viral load increases so much and their CD4 plus T cell count or their white blood cell count decreases so much. And that's where we can assess the level for diagnosis of AIDS. And there is an urgent need to expand access to HIV prevention and treatment for all gay and bisexual men, underscoring the importance of the federal initiative Ending the Epidemic, a Plan for America. Racial disparities. Among gay and bisexual men who received an HIV diagnosis in 2018, racial and ethnic disparities continue to exist. At the top, you can see there 37%, 9,712 were in the community of the Black and African American community. Right under that, Hispanic and Latino, 30%, 7,996. And then we fall to white, Asian, multiple races, as you can see. At the bottom of this infographic, which was gathered from the CDC, you can see that Black refers to people having origins in any of the Black racial groups of Africa, and African American is a term often used for the Americans of African descent with ancestry in North America, and Hispanics, Latinos can be of any race, and typically within our world, we refer to them as Latinx. So what are our challenges to prevention? Our current challenges in addressing such high and disproportionately affected populations, such as gay and bisexual men? Well, specifically for this population, first, one of the challenges is recognizing the disproportionate effect of HIV among that population. And so really bringing that to the forefront, recognizing that this is the issue, this is where it lies, and this is the community that needs to be better addressed, better educated. Services need to be increased within this community. They need to be engaged more. They need to be energized to be proactive in this. We also need to address the challenges that are ongoing, especially within the Deep South, of stigma, homophobia, and discrimination. Those play a pivotal role in prevention of HIV, as well as progression of HIV, and it filters through all of the stages, all of the important stages of testing, medication adherence and care, social support services, reaching out to those organizations when you are living with HIV to receive the services that you not only need, but most importantly deserve. And homophobia, discrimination, and stigma all play a role in knocking these gay and bisexual men down mentally so that they think that it's almost impossible for them to reach out and achieve this, or it's too scary for them to go get tested because they don't want people to know their business or to spread their business. And I think in addressing and understanding those, that would also play a large role in assisting us in better understanding how to end the HIV epidemic, and also assist us in understanding what our role can be on these national awareness days, such as National HIV/AIDS Awareness Day for gay and bisexual men. And then 1 in 6 gay and bisexual men with HIV are completely unaware of their HIV status. And that is big, 1 in 6. And this comes from many factors. Most specifically, I would assess this as point this to 2 factors. Lack of comprehensive sexual health care education, which means that the education is not there to understand the need for testing, and so therefore they do not get tested. And then number 2 would be that stigma, discrimination, homophobia, all playing that internal mental role against these individuals in whatever part that it plays, so that they never get tested. They never have these healthy sexual conversations with their partners or with their friends, peers, family members to better understand the importance of testing. And so it continues to be pervasive. Additionally, anal sex puts gay and bisexual men at increased risks. Receptive anal sex is 13 times as risky of contracting HIV as insertive anal sex. And that's also extremely important. The tissue within the anus is extremely thin and extremely permeable. It is the highest, it holds the highest risk of transmission of HIV because of that reason. And so therefore it increases this population's risk of contracting HIV. Additionally, PrEP use. PrEP stands for pre-exposure prophylaxis. It is a 1 pill once a day It is taken to prevent HIV, and it is 99% effective. One pill once a day to prevent HIV for those that are at higher risks. And PrEP use among gay and bisexual, Black and African American, and Hispanic and Latino remains very low. Only 19% of Black and African American gay and bisexual men are currently using PrEP, and only 21% of Hispanic and Latino gay and bisexual men are currently using PrEP. And that is compared to 31% of white gay and bisexual men who are currently using. And then we can kind of fall back to those social determinants of health to better understand and assess why these numbers, the statistics is the way that it is. And we already know lack of education within those communities, lack of access to healthcare, lack of equitable healthcare within these communities, socioeconomic factors, lack of providers who have current, up-to-date, medically correct information on HIV and HIV prevention. And then falling through those socioeconomic factors, the limited access, quality to healthcare, lower income, education levels, higher rates of unemployment, substance abuse, and incarceration all become challenges to prevention and play into becoming factors of contracting or transmitting HIV. So what is it that we can do now? Because these National HIV/AIDS Awareness Days, the goal of these awareness days is to increase community involvement, increase community education, allow us to become collaborative partners to understand what the goal is together and to address and assess and immediately take action. And so first thing would be educating ourselves and then taking that outside. You know, this information that we learn at work or in webinars such as this does not have to stay with us solely. It's important to take that information that you learn, better educate yourself on it, become more well-versed on it, and then implement that in daily conversations, either with coworkers or peers or family members, consumers, and the community which we serve. Then through that education, we can act on it. We can become proactive in joining HIV-focused community groups, organizations, nonprofits. One that I'm a co-chair on, as well as Tony, is End HIV Alabama. And that is our Ending the HIV Epidemic cohort. And so we meet once monthly, and it is based on community involvement. And so all it takes is individuals being interested in finally stopping this virus where it stands, to just take part, listen to people's stories, become better educated through learning from people who work in this daily, so that you do know what those actionable items and steps can look like and can be for you. Cultural competence and expanding your cultural responsiveness is extremely important. That would allow us to embrace and better understand the gay and bisexual communities, their risks, their needs, and their social determinants of health that are more specific to them and their communities. We can also address stigma head on. Stigma stems from ignorance and a lack of education. And for me, those two are separate. A lot of people align those two, but while education is everyone's right, not everybody is provided it. And so the ignorance is perpetuated. I could sit here and talk to 50 men right here in Mobile and never break a barrier with them, because they're not going to listen to me. They're not going to understand me or believe me, because I'm a gay man living with HIV, talking about gay men living with HIV. And so for me, that's where ignorance continues to lie. But through addressing those, the ignorance and the lack of education, and more entirely the stigma, eliminating that stigma really allows for expansive growth through HIV as a whole, for individuals to really come to terms and understand that testing is important. It needs to happen. It needs to occur. This is what testing looks like for me. Assessing my risks are important. Talking about sexual health in a healthy and responsive manner is encouraged. And then we move on to leaning on those community partners and organizations who are already doing this work to help them achieve their goals and their mission. And that may look like becoming a volunteer, or assisting with a setup, or standing at a table, helping with a food bank. All of those, what seem to be such small parts in volunteering, really add up to a much larger role that you are playing in truly ending the HIV epidemic within our communities. And looking at some statistics, lifetime HIV risk among gay and bisexual men, and for me personally, these are very startling. We've already mentioned the 1 in 6 gay and bisexual men are at risk of contracting HIV. However, 1 in 2, say that again, 1 in 2 African American and Black gay and bisexual men are at risk of contracting HIV in their lifetime. And that's where we stand right now on our knowledge for HIV. That, if it's not addressed, just like any other statistic, can become worse. It can become 2 of 2. It can become 100%. And that's really where it's going if we don't accept it for what it is right now and address all of these factors to truly take action and work during these national awareness days to expand this education and community involvement. Additionally, 1 in 4, which is also a very startling and unsettling number, Latino gay and bisexual men have risk of contracting HIV in their lifetime. That is it for my presentation. I hope it was everything you needed to hear today. There's my contact information. Christina has it as well. I'll put it in the chat once I figure out my screen and how to get it back up and going. But that's my agency, our address, my office number, my direct line, and then my email and our website as well.
Thank you so much, Shey. Virtual round of applause. This was such great information, and I thank you so much for stepping in and giving it to us. Excuse me. One question that we had was if you would be willing to share your slides.
Oh yeah.
Okay, great. Then I will be sure to share those with those of you who are on the call or on the webinar today. I'll also share the recording if anyone wants to share this information with their colleagues. I had a few questions that popped up for me throughout your talk, and I'm going to ask those. And if other folks have questions, this is your time to drop them in the chat. But before I do that, I want to just make a quick point that if you would, I'm going to drop our evaluation into the chat as well. For those of you who are on, if you'll click that form, it's a Google form, it's anonymous. If you'll just fill that out, it helps us to make sure that you're getting webinars that are meaningful to you and helpful for you, and helps us to be better for those future webinars. So it, very simple, open-ended questions. What was most helpful, what was least helpful, and that'll really help the campaign put together these webinars going forward. So if you'll take a moment, I just dropped that into the chat, just click on the link. So the first thing I wanted to say, you were talking about the statistic of 1 in 2 African-American gay and bisexual men will be diagnosed with HIV, which is like such a startling number. And I just want to point out that I think it was last month, Tony was part of a production in Birmingham, and I totally do not remember the theater troupe's name, but it was a theater company that was all LGBT, I believe, probably all Black individuals, and they had this theater company, and they put on these very meaningful activist productions. Anyway, it was called 1 in 2, and it was telling the story of this person who was engaging in sexual activity with another. It was a man engaging in sexual activity with another man, and he finds out he is HIV positive and doesn't get on the medications that he needs to get on. It's just kind of like his life journey. And it's just, it was so well done, well produced, well directed. And I think Tony told me that they might be doing it again. So if they do, I will share that with this list of folks, because I think if you have the opportunity, or if you're in Birmingham to see it, it was just really meaningful and impactful for me. So, that number will always stick with me. It's just crazy to think about half of that population. So one thing that you said, you were talking about undetectable means untransmittable. I know what that means, but can you share for others who may not know what that means? That's a little bit more of the HIV 101, but I would love for you to touch on that.
Absolutely. So when an individual contracts HIV, what HIV does within their system is it targets specific cells. And those cells are called CD4 plus T cells, also known as white blood cells, or better known as our immune system. And it attacks those cells by entering it and reframing it, renaming it, essentially, is a better way to say that. It recreates this cell to become a virus cell. And that continues to happen. It continues to do what we call replicate or replication. And therefore, the viral load, and there are two important numbers that we look at in HIV, viral load and a CD4 count. And so therefore, a CD4 count, which is typically between 600 and 1200 for a healthy individual, will decrease continuously as that viral load number, or the amount of HIV in their system, continues to increase. And that also can allow us to better understand those three stages of HIV: acute infection, clinical latency, and then further progress to AIDS. So whenever medication is applied, and medication nowadays is called antiretroviral therapy, and more simply, we just call it ART, A-R-T. Whenever medication is taken as prescribed, which is extremely important, whenever these individuals maintain medical adherence, seeing their doctor on a routine basis, getting this blood work, ensuring that the medication is working for them. For a lot of people, this is one pill once a day. Personally, for me, my story, I started off on one pill once a day. The name of the pill was a triplet, and I had horrible side effects with it, mental side effects, but my doctor made me stay on it for over 4.5 years. And then I moved on to another one pill once a day regimen, and it worked very well for me. Well, most recently, we have gone to a 2-shot once a month regimen. And this is all by, it's decided upon by the patient and the provider. So currently for me, my new regimen is 2 shots. One is called cabotegravir and the other rilpivirine. And they come together to make an injection called Cabenuva. And so my treatment for HIV is now once a month. I don't have to worry about taking a pill every day, which is a huge relief off of my shoulder. My family that I may not want to know my status won't see my pill bottles or ask questions. My point in saying this is that medication has progressed so far throughout these 40 years of HIV and AIDS that now it is so effective that it reduces the viral load and works to increase that CD4 count. Well, in reducing the viral load, individuals who are living with HIV can achieve something called viral suppression. And there are specific number indicators now, so many copies of HIV that they look at, and I don't know that off the top of my head right now, but that allows the provider to determine if this person has reached viral suppression from the medication working. Excuse me. And so what viral suppression is undetectable. And that means that because this person living with HIV is taking their medicine is working, and the virus is suppressed so low, it cannot be detected through normal blood test, quick, rapid, or Insti test. And therefore, because it cannot be detected, because it's not easily accessible, we'll say, it cannot be transmitted. It can't be passed along. And that, although we don't encourage it, that includes unprotected sex with your partner. That includes having sex with somebody who may not be on PrEP, the pill that prevents HIV. That includes an accidental stick from someone who may work in the nursing field or other healthcare industry. If that individual is undetectable, has achieved viral suppression, they simply cannot pass the virus along. And that really further goes to prove and show why we need to, and I'm glad this question was brought up, why we need to enact these two very important things and how they will assist us in ending the HIV epidemic. Because for those living with HIV, we can stop their transmission completely as long as they are on medication. And then for those at risk, which generally speaking is most of us, let's be honest, a lot of our government and CDC and state healthcare departments really like to focus on populations. But in my opinion, everyone is at risk depending upon, what they partake in.
Right.
But through enacting HIV medication for those living with HIV, achieving viral suppression, and then implementing increased PrEP use, and we saw the low numbers of intake for PrEP to prevent the transmission of HIV, then we stop HIV completely in its tracks. And so I think a larger issue with that is people knowing their status.
Yeah.
And that's where that stigma and fear come in, because so many people are simply afraid to get tested, that they'll never know their status. Therefore, they will never be on medication, never achieve viral suppression, and their partners will never know to get on PrEP, and the circle will continue.
Yeah. That's so amazing to think. I mean, just to think how far we've come in 40 years, and just medical science is so amazing that we have these drugs now that can, even though someone is living with HIV, they couldn't even transmit it to a partner. It's just amazing to me. You talked briefly about PrEP, but I wonder if you can just speak a little bit more about it. And I know there's also PEP, and just like, what is the difference between those two, and who are they? Like, who's being targeted for those drugs to take those drugs?
Absolutely. So we'll start with targeted communities for these drugs. They assess who is most at need for these medications by risk factor. And so in looking in the realm of sexual health, we examine risk factors for individuals through testing and through medication and through treatment all the time. And so risk factors can look like who you've recently had sex with, and I kind of touched on this previously, who you recently had sex with over the past year, whether that be a man or a woman, if you've had vaginal or anal sex, if you've used injection drugs, if you've been with a partner who uses injection drugs, if you have sex for drugs, food, money, or something you need, if you have sex with someone who has sex for those things, if you've had a blood transfusion, transplant, hemophilia, all of these little factors go into play and allow us to assess the risk of an individual for contracting HIV. And obviously, the more boxes you mark off, the higher risk you are. If you are a gay man and you mark off, the only thing you mark off is that you've had sex with other men, you're immediately at the highest risk. If you're a trans woman, high risk. If you're an African-American individual, but more specifically gay or bisexual or trans, exceptionally high risk, as we've seen within that one and two. And so that's how they assess who is, the prime patient candidate for these medication, is through assessing their risk. And the higher risk you are, the more susceptible to HIV you are, the more important it is for you to take PrEP. So PrEP stands for pre-exposure prophylaxis. Before, exposure, you are exposed, prophylaxis. It's a barrier, a medication that we take to protect ourselves, right? And so PrEP is one pill once a day. There are two brand names and now a generic. So it is Truvada and Descovy, and a generic has now come on the market with more PrEP coming out after the first of the year, according to our pharmaceutical sales reps. And it is widely viewed as 99% effective in preventing those who are at highest risk of contracting HIV from actually contracting HIV. And so we have our clinic, Shell Health, that stands for Sexual Health Education, Learning, and Living. We started off as a PrEP clinic. And once individuals knew that they could come and receive these free services, see a medical provider, get blood work, get the medication shipped to their door, we saw an increase in uptake of this medication for those who needed it. But then we also saw this beautiful growth in the population that was interested. Ironically, a lot of heterosexual white women coming to get on PrEP. anyway, so that is what PrEP is. PEP stands for post-exposure prophylaxis. And so this is taken after someone has been exposed to HIV. It can only be prescribed and taken within 72 hours of exposure. So you have that 3-day time period where it's really important for you to speak with a provider or have that community agency or organization that you can, lean on. And I see that Kelsey Bryant is here with Lifelines, and they also do the same work. We're working together on this as well, and with the University of South Alabama. But that regimen is 2 pills, and it's actually, all of these medications are made up of what is used to treat HIV, which is ironically beautiful in itself too. And so it's 2 pills once a day for 28 days, and it will completely eliminate your risk of contracting HIV if you were exposed. And I probably talked way too much, but I hope that was the information you were looking for.
That's perfect. So I would think PEP would be in, like, when I'm thinking about sexual and reproductive health, and specifically what the campaign is doing, a little bit like emergency birth control. So let's say you were sexually assaulted, emergency birth control and PEP would be kind of like the regimen that you would want to make sure that you were talking to your provider about.
Absolutely.
After an event like that. Okay, that's great to know. Or, like if you got stuck, if you're a nurse and you got stuck at the hospital, I imagine that they would also take PEP. So that's great to know the difference between those two.
And I will say, Christina, if I can, super quick, it's important also for everyone on the webinar today and learning this information to help people navigate PrEP and PEP. We have a lot of providers. One of our goals for our EHE grant is to address the lack of education within our providers in Alabama in regards to HIV, PrEP, and PEP. And so we have a lot of providers in Alabama who refuse to write prescriptions for PrEP. Just as much of them refuse to treat STIs. We see it almost daily down here. Our emergency room has a very difficult time with prescribing PEP. And we have had many, many people that come to our organizations a day late and out of pocket because they wasted money at the emergency room and they can't get the medication that they needed. And now their risk has skyrocketed. So really, in all of this information that you're gathering today, I think it would be really important to better understand what those organizations within your local community are so that you can assist your consumers and community members in navigating that situation if it ever happens to them. Absolutely. And so that you can allow them to understand that you hold a safe space, that they can come to you to talk about those things so that they don't take the wrong steps and end up a day late.
Wow, that's heartbreaking. I can't imagine how hard that would be to turn someone away from that drug just because they're a day late. That's awful. And shocking that emergency rooms wouldn't be carrying it, considering what we just talked about. So since you brought up medical providers and those who are unwilling to write prescriptions for PrEP, can you talk, I gave a talk, it's been a couple months now, but at a school nurses conference, where I talked about some of the data around LGBT and specifically trans folks who reported discriminatory practices by their healthcare provider. Healthcare providers that wouldn't touch the patient or were just taking excessive precautions to treat the patient once they knew they were trans or LGBT. Can you speak? And there was someone who came up to me afterwards who was just sort of in disbelief. I couldn't believe, because they were a nurse, couldn't believe that another medical professional would treat a person that way, treat a patient that way. Can you speak to, like, maybe even anecdotally, that those data points that we see in our last few minutes?
Absolutely. So we see such increased rates disproportionately within the communities that we focused on today, and especially within the trans identifying community for this very particular and specific reason. Medically accurate education, information, and healthcare provision is missing for our communities. We do not have enough providers who are well-versed and well-educated on what primary care for a gay man may look like. For instance, Who knew that gay men should receive an anal pap smear once a year, right? Nobody knows that.
No.
And it's so sad. But because of the increased risk of polyps developing and eventually anal cancer or things like that, because of anal sex, that is why that's needed. And so many providers have no clue on that, right? But then we go to the trans identifying community and hormone replacement therapy, trauma-informed care, psychiatric care, and not to change their goals in achieving who they want to be as a person or who they see themselves as, but psychiatric care and ensuring that their mental health is stable throughout this transition. It's all missing, and it's missing due to the fact that stigma continues to be pervasive no matter what profession you are in. Ignorance is completely bliss, and people thrive in it. And we have this kind of awkward balance of, do I, as a health educator, know more than a medical practitioner? And will they listen to me if I speak to them? Or will they even ask questions or be interested or implement any of these changes? And so far, what we've seen is there is a huge refusal to do that. And so I think that needs to be better addressed from our organizations and agencies like ours, and those represented here today, but also addressed at a larger state or national level, because that is not healthcare. If we can't provide this individual, regardless of their sex, race, sexual orientation, sexual identity, with the most top-notch healthcare that they deserve and that they need for their specific needs, then we are not providing healthcare. And so that's really what our clinic is working towards as well, is being completely inclusive and welcoming, equitable, and ensuring that people who have perpetually been thrown under the rug in regards to their healthcare are finally getting their needs addressed. And we're seeing it happen throughout the United States. We really are. And the University of South Alabama, our local college here, is really being proactive and taking steps. They have us come educate their medical students and their nursing students. And we go out there once per month and take our mobile testing unit. We will be to provide free STI testing and PrEP. And we have a partnership with their sexual abuse and violence team to provide PEP. And so people are taking steps, but I think they need to know that there are steps that need to be taken first.
Right. Well, that's like a great call to action for it to end up, like a note to end on, is knowing where folks in your community can get inclusive healthcare and trying to navigate those systems, and how can we bring more inclusive healthcare for our vulnerable populations. Thank you so much, Shey, for coming and educating us. And I think just this ending time of being able to answer some of these questions was super helpful. So thank you so much. I hope we can have you back to talk about HIV some more, or other related sexual and reproductive health. We'd love to have you back. So thank you. And for everyone who's still here, I'm just going to share one more time the evaluation in the chat, because it really helps us, and it helps our funder know what we're doing. So if you will just click on that before you exit, it'll take you to Google Forms, and we will hopefully see you all next month. Let us know if you have any questions. Shey just has their contact information in the chat as well. So reach out if you have any questions, and we'll see you all next month. Thank you.